Hi everyone, welcome back to my channel. My name's Lucy and I'm a junior doctor working in the UK. In today's video I'm going to be talking about life as a junior doctor. I started my FY1 year in August, so I've been a junior doctor now for about 6 to 7 months, and I thought now was a good time for me to reflect on my experiences so far and also to try and give any tips to any current medical students who will be becoming junior doctors this August. I asked for some questions on my Instagram story, and so I'm just going to go through and answer your questions and hopefully you'll find this helpful. So the first question is, what is the hardest thing about transitioning from medical student to F1? Now, the first thing to say here is that I really do think your knowledge as a final year medical student who's just finished finals is as good as any F1 doctor, if not better, because I think when you start working as a doctor, you lose a lot of your kind of textbook knowledge because a lot of it becomes less important, but you do pick up a lot more kind of practical, on-the-job kind of knowledge. I think the big step is having responsibility for your patients, and as a medical student, you might have had lots of practice of reviewing patients, taking bloods, looking at results, coming up with plans, but you never actually are responsible for the patient because you're always being supervised by a doctor. And although the F1 role is still very supervised by senior doctors, you do have to take responsibility for your patients. Whether that's patients on your ward, patients you clerk in A&E, you are the person responsible for completing all of the jobs for those patients, managing any issues that come up, updating family. Essentially, it's that no one else will do your jobs for you. So, if you want a certain blood test for a patient, you have to make sure you chase up that result. And if you're not going to be able to chase it up because you're going to finish your shift, you need to make sure you hand it over to an evening doctor or a night shift doctor. If you order a scan and it's not being done, it's your responsibility to chase up with the X-ray department and try and get that scan done and then to review the result of it. So it's kind of this having responsibility for the patient. I think another thing is that when you start introducing yourself as a doctor and you have doctor on your name badge, a lot more so than with a medical student, there's that automatic real trust in you from the public, from the patients and their families. And they're not going to necessarily know that you've only been a doctor for 1 month. They're going to expect you to kind of know what you're doing and look after them. And I think that's something that takes a bit of time to get used to. So I'd say those two things, and also the fact that when you're a med student and you're in placement, you often just kind of do a half day, or you'll see a few patients on the ward round and then you can kind of just head off and go and revise or do something else. And obviously as a doctor you actually have to do the full shift. So just in terms of energy levels and getting used to working full-time or part-time if that's what you're going to be doing, then that's obviously a huge transition, but that's true for anyone coming out of school or uni and starting a job. The next question is, what would you have done on placement to prepare you for life as a junior doctor? So I think it's tricky at med school because a lot of your placements do centre around passing exams, and therefore the key things leading up to finals that you're focusing on are knowledge-based and skills-based. So, you're practicing taking bloods and ABGs, you're taking histories from patients to practice your history-taking skills, and then a lot of the time you're just learning lots and lots and lots of facts about medicine. And all of those things are really useful. But I think the thing I probably realised was my biggest weakness when I started work as a doctor was all about decision-making skills. And what I would say is that if you have a sort of assistantship type placement, so in Nottingham we had one where for a few weeks we shadowed an F1, but we were kind of meant to be trying to take on the role of an F1 and practice the everyday jobs they have to do, rather than just kind of being on placement to learn medicine. What I would do on one of those placements is to practice simple decision-making skills. For example, I'm on geriatrics at the moment and I do my own ward rounds. Multiple times a week I will see a bay or a couple of bays of patients on our ward independently, and I will make the management plans for them. And obviously there are senior doctors that I can discuss those plans with, but I think looking back that was the thing I practiced the least on placement. So it's simple things like, if a patient is coughing during the ward round, do you need to investigate that further? Do they need a chest x-ray? Do you need to send a sputum culture? Are you happy just listening to the chest and knowing it's clear? Do you need to do a viral swab? It's that simple decision making of, am I going to investigate something further? Do I need to start them on empirical antibiotics in case they've got a chest infection? I feel like if you can, on your placement, just try to, before the doctors actually make a management plan, try to come up with what you would do in your head and just see how it compares. There's not always necessarily one right management plan. I feel like that's another thing I've really learned, is that doctors have very different thresholds for when they investigate, when they start treating something. There's not necessarily 100% right or wrong answer, but just get into the habit of practicing coming up with management plans. And when you're going on ward rounds, rather than just kind of zoning out when you're listening to the doctors review the patients, try to actually think, what is your agenda for that patient? Like, when you go to review them, what things or what questions are you asking yourself? So whereas when you're on placement, you kind of are more thinking about diagnosing things and how you manage things, think more holistically and think about the main aim for every patient is to get them home and get them home safely. So every day you want to be asking yourself, is this patient medically fit yet? Are they ready to go home? And if they're not, then what's keeping them here? Could we switch their IV antibiotics to oral so they can complete the course at home? Are they still needing oxygen? Are we still investigating something? Could that investigation be done as an outpatient? When they're going home, where are they actually going? Do they need further support, like a package of care? Might they need a placement? There's all these kind of questions that maybe as a med student you don't think about so much because you're so busy learning knowledge, but actually that becomes a pivotal part of your ward round when you're a doctor, especially on placements like geriatrics. So the best thing you could probably do, like I said, is to try and come up with management plans in your head before the doctor makes their own management plan, and practice prepping notes as well. So then you're actually thinking about that agenda for the patient, like what are we trying to establish when we see the patient today? So look at their blood results, look at their OBS, look at any investigations that have come back, and try to sort of build a picture in your head of how unwell the patient is and what things are keeping them in hospital and what things can be done moving forwards to get this patient home. And I feel like if you start doing that on an assistantship placement, you're going to be in a really good place when you come to start F1. I then had quite a few questions about hours. Are the hours difficult? What are the shift patterns like? So I thought I'd give you a sort of breakdown of the types of shifts that I do. I'd say that it really fluctuates. Sometimes it feels just like any job and it can be 9 to 5. At times it feels really exhausting, and I feel like I'm in the hospital for so much of my life. But it really does vary, and I think actually I have really started to just get used to the shift patterns now. Essentially, we have normal ward days where it will be kind of a typical 9 to 5 day, maybe a bit earlier, 8:30 till 5. That is the majority of the job, to be honest. Some days you might have a normal ward day, but you might be doing something a bit different. So when I was on cardiology, a lot of my shifts would be post-take shifts. So when you go around with the consultant, seeing all of the new cardiology patients who've come into the hospital, making a consultant plan for them, and then spending the rest of the day kind of doing the jobs for the new patients. So that's kind of a different type of shift, but still a normal working day. We then do day on call shifts, which are 9 till 9:30. It's probably different in every hospital, but in our hospital, our on call shifts are a mix of clerking patients in A&E or AMU, in other hospitals, but a lot of our patients are in A&E. So that's seeing new patients, taking a history, examining them, ordering investigations, coming up with a plan, and then they get seen by a consultant as well later in the day. And then the other sort of part of the on-call shift is ward cover. So when all the ward doctors go home at 5, you're then responsible for covering the wards, and that's answering bleeps from nurses who are worried about sick patients. On-call shifts can be very varied in terms of what kind of things you have to deal with. Sometimes it's simple prescribing pain relief for patients, sometimes it's reviewing people that have suddenly deteriorated, and while you're on call you also have the emergency calls that you have to attend. So in our trust we have obviously cardiac arrest calls, medical emergency calls, and then there's other things like massive blood loss calls, stroke calls, and essentially depending on what bleep you're on, you're responsible for attending a certain number of those emergencies. So that's a day on call. A night on call is basically the same, but it's just switched. So it starts at 9 p.m, finishes at 9:30 in the morning, and that's including a handover as well. So often it finishes a bit earlier than that, actually. And on those shifts, you're either clerking in A&E for the whole 12 hours, or you're on ward cover for the whole 12 hours. We then have twilight shifts, so that's kind of starting work in the afternoon, working into the evening. But they're actually quite nice shifts because you get a morning to yourself. Oh, and you also do weekend on calls, so that's when you're in the hospital for Saturday and Sunday, 12 hours both days, and it's again kind of a mix between post-taking patients and being on ward cover. But in terms of, you know, the shift pattern, I've actually only done 3 sets of nights. So I did 2 sets of nights in my first rotation, 1 set of nights in this rotation, and it will only be 3 or 4 nights in a row, so it's not actually been too bad. There are long shifts, but they are spread out. The day on calls will happen every kind of week or so. Some weeks you might have 2, some weeks you have none. So it kind of just really varies each week. And that is difficult because you're never in a routine. But then I also feel like it kind of keeps the job a bit more interesting. You're not just working 9 to 5 Monday to Friday. You will have random weekdays when you're off. When you have twilights, you obviously have like a morning and early afternoon before you have to go to work. There's pros and cons of it, but I do find actually it's not too bad. But at the end of a weekend or a set of nights, I'll be saying that it's awful and I find it really exhausting. So I had a few questions about work-life balance, how to maintain balance. I think it's kind of with any job. This isn't necessarily specific to medicine, just, going into full-time work, you do realise suddenly how much less time you have. I think it's just trying to find ways to fit the things you want to do around shifts. I think when you do a 12-hour shift, it is difficult because if I'm working Saturday and Sunday, 9 till 9 both days, realistically, I can't really do a lot that weekend unless I get up early to exercise and things, or unless I do something after work. But at that point, I'm getting home at nearly 10 o'clock and I'm just exhausted. So those sort of shifts, I just have come to accept that I'm not going to do anything other than work in that weekend. But that's those weekends don't happen very often. For a lot of the time, it is normal shifts. So don't worry about suddenly not being able to do anything else other than medicine. I think what was helpful for me was when I just started, I was also training for the London Marathon. So I kind of had no choice but to make sure that I was running really regularly. And I had a really detailed plan of exactly when I was going to run and what runs I was going to do. And so when I'd come home from work, no matter how tired I felt, I would know that I have to go on this certain run and I would just do it. And I mean, since the marathon, I've probably not been as good at keeping on top of my running. It's all about just being committed to carrying on the things that you want to do. Something that works really well for me and the other F1s at my hospital is we basically started this running group where we would run from the hospital straight after work. So it just turned running into a bit of a social, and it kind of made us all quite motivated to go because we know we're going straight after work and we're not having to go home first and then get changed and go out again. It was something we did straight from work, so that's worked really well. I think if you can start something like that up, that's really useful. So the next question is tips for incoming F1s, things you wish you knew before starting. Firstly, don't be afraid to ask your seniors. I think there is a danger to being a very overconfident F1 and feeling like you can manage everything yourself, because you haven't got that experience of having worked for years and years. So use your seniors, learn from them. Don't be afraid to bleep them and ask them questions. I would say make sure your handovers are good. So this is again something you could practice on your placements. When you are bleeping a reg, for example, especially if it's like on a night shift or really busy on-call shift, you need to make sure that you can give them a really concise, quick, clear summary of the patient and what your question is. So at med school, you obviously learn the kind of S-bar approach to doing that. And although I'm not necessarily always thinking in my head about S-bar and what it stands for, I do think that that's a really good template for how to just get your point across to a reg. I remember at the beginning there were a few times when I kind of forgot that I had to present the patient clearly, and I'd just kind of be waffling a bit and asking loads of questions in one go. It's then really difficult for them to give you a good response back. So just take that time to, have a look through the patient's background, make sure you've actually spoken to the patient, examined the patient, looked at their drug chart, you've looked at their bloods and their obs, so that you're ready to actually give some clear information to your senior. And then if they ask you questions back, you've got all the information to hand. So that's one thing. Secondly, the guidelines are your friend. So at med school, I feel like because you're always learning for exams, you're trying to always keep all of this information in your head, and you just don't need to all of the time. I mean, it's quicker if you know doses and things off the top of your head, but realistically, you're not going to remember all of them, and especially when you're tired or you've been concentrating or making decisions for a long time, it's really nice to have those guidelines to back you up. So even if it's something like someone's got a low potassium level and you just can't remember if it's bad enough for them to need IV potassium or whether you can just give Sandocaine, things like that, just use the guidelines, because it's often really, really clearly set out. It just tells you what to do. So yeah, remember the guidelines are there, and definitely get the kind of antibiotic guideline for your hospital as well, because antibiotics will vary, and that's again is really straightforward to use because it just tells you what antibiotic, how long for, what dose, how many times a day. So that's really good to use. Another really important thing you can always fall back on is A2E. Whenever you turn up at an emergency call or you're bleeped to review a patient who's become unwell, just use that A2E approach. When you get to the end of your A2E, you will be in a better position to make decisions about a patient, and that is just always true. Even if it's simple things like starting oxygen, doing an ABG, taking some bloods, it's going to help you having done the A2E. And if nothing else, then it just means that when you call a senior to ask for some help, you've got that A2E that you can easily talk through and you can tell them your findings, especially when you're tired in the middle of the night. That is the thing that you can just always fall back on, and it will just get the ball rolling. You'll start making some progress. And the last sort of tip I would say is remember that you're learning still. So even though you're not a med student anymore, medicine is always going to be about learning and acquiring new knowledge and improving your skills. So just don't put yourself down if you're confused about a diagnosis, or you can't come up with a good management plan, or you miss bloods, or you miss a cannula. You're a foundation doctor and you're in training, so I think just don't beat yourself up about those things, and it's honestly amazing how quickly you learn. I think when I look back to myself in August when I was just starting compared to now, the way that I just work and review patients is so much more efficient, and I feel so much more confident reviewing patients, especially when I'm on call getting bleeps and things. I just feel in such a more comfortable position than I was a few months ago, and you really will feel that change in a matter of a few months. So I had a lot of questions asking me about the most exciting thing about being a doctor, or in the media there's often lots of negatives about being a junior doctor. What are the positives? What's the most surprising thing about being a doctor? Although this sounds so cliche, the best thing is that I do come home most days feeling like I made a difference. I didn't necessarily save someone's life, but I think as a doctor, you're in a really privileged position of being able to define someone's healthcare experience. If you're kind to patients and empathetic, and you give them time and you listen to them and you explain things clearly and you update them as things change and you offer to update their families, these things make such a difference to that patient. And it's so lovely to actually sometimes get feedback from patients and them, say thank you for actually bothering to, spend that much time with me, or thanks for actually calling my family. And those things are what make it really worth it. Also, I think it's just a really cool job. And sometimes I just sit and think how amazing it is of how much knowledge we actually learn from med school, like the amount that we know about the human body, and that's still at very early stages of our careers. Being able to come up with diagnoses and knowing what to prescribe and seeing patients get better is just so rewarding. And I think those are the things you have to hold on to when the shifts are long, when you feel really drained, is that you have the ability to actually improve someone's day. And I really think communication skills are just everything in medicine, and one of the things that I'm always going to be focusing on improving is specialism on geriatrics at the moment, and a lot of my conversations are about sort of respect forms, you know, DNA CPR, sealing of care. For me, improving those kind of conversations is a really rewarding skill to be developing every day, and I really am feeling that skill develop. The last question I wanted to finish on was, is it as terrifying as it seems? And I really mean it when I say that no, it isn't. I remember watching there was a programme on ages ago called like Junior Doctors or something, and it was following the lives of a few junior doctors and their kind of first few shifts. And I remember just thinking that I could never do that. And the fact is that you just can do it, and you will do it, and you'll just learn every day, and you'll get a little bit better every day. And you will struggle with decisions, you know, there'll be times when you feel really out of your depth, but there's always a support network around you. Speak to your seniors about patients you're worried about. If you want to check your management plans for patients you see, then check them, use the guidelines, and just try to enjoy, like I said, the fact that you can have an impact on someone's day. You can make their experience of healthcare better than it might have been. So I hope that video was helpful. I feel like it was very rambly. I feel like I'm going to turn the camera off and there's going to be so much more I wanted to say. Good luck to everyone who's going to be starting work as a doctor in August. Try not to worry about it. Try to enjoy it. You'll be great. And I hope to see you soon for my next video. Bye!